Okay, well, I think I'll get going. I have a minute or so past 6:30 Central Time here. So for those of you who can listen in, let me just kind of thank you again for jumping on the call. First of all, let me just do a quick audio check. Nathan, can you hear me okay?
Yep, you sound great.
Great. Josh and Maderick, are you able to hear me okay?
Just fine.
Yep, loud and clear.
Good, thank you. Well, again, let me thank everyone for joining in. I know there's a lot of fantasy football interest out there, and we're right in the middle of a couple of football games tonight, so I appreciate you taking the forbearance to participate in this webinar. By introduction, my name is Juggy Gill. I'm the founder of Tenex Health, and I have the great benefit of participating in this webinar and introducing two of our speakers, or two of our participants rather, Dr. Josh Hackle and Dr. Maderick Hall. The plan for the webinar is the following. I'm going to just share with you a few slides. Hopefully you should be able to see, if you've jumped onto the webinar, you're able to see the title slide of our talk. And the title is Physician Webinar, Dr. Josh Hackle, Dr. Maderick Hall. There are a few slides that I like to go through. I know for many of you listening in, the technology is relatively new to you, as well as our clinical experiences. So I thought it'd be wise for me to at least provide you the state of that. And then what we'd like to do for the balance of the webinar, and really the meat of the webinar, is to have both Dr. Hall and Dr. Hackle provide their experience with the technology. They both are kind of household names, if you will, in sports medicine, and they have unique practices, and so I think you'll benefit from their optics in terms of how they've utilized this technology. So one logistic question, as we go through the webinar, you'll have the ability to type in a question. We're able to see that question is anonymous. So we're able to see that. So as you type in that question, what we will do as we finish up the webinar, we will answer those questions at the tail end of the webinar. So feel free that as we go and talk, please type in your questions that you want the panel members to address. And then at the very end, we will open up the mics so that if anyone wants to ask a question directly to Dr. Hall or Dr. Hackle, you're able to do so. We reserve that at the end so that it minimizes any of the noise from the interference with the microphones. So with that, let me get started. Nathan, if you can progress to the next slide. What I'd like to do is maybe kind of set the stage of why we're interested in this disease process. As many of you know, Mother Nature does a great job in terms of addressing tendonitis. If you look at this slide that identifies the disease process, there's a recent article that came out at the American Journal of Sports Medicine that through conservative measures, 75% of us, after we've been exposed to this initial insult that moves us from a healthy tendon to a acute inflammatory tendinopathy, 75% of us will heal ourselves. So Mother Nature does a pretty good job. So we go on and then we take a fourth down, if you will, and we have then healthy tendon, and then we have relief of pain. The balance of us move into this chronic degenerative condition. So it's no longer inflammatory. You have dead tissue, you have apoptotic cell death, and the data is pretty clear is that that pain generator needs to be addressed. An intervention needs to be delivered to remove that necrotic tissue to allow that body to remodel and heal and kind of go back to a normal looking tendon replete with any kind of pain profile. Next slide, please. So that's where we're about. We're in that chronic tendon patient population, and we utilize the imaging benefits of ultrasound. As many of the people on this call know, ultrasound has quickly been adopted because of its precision for soft tissue. It's very mobile, and it doesn't have any noxious effect to the patient. And most importantly, I think for us, you can do interventions with the guidance of ultrasound. And that's what this slide tries to identify. Looking at the elbow and epicondylosis, as many of you know, that's an overuse injury. It's typically not of traumatic origin. But there you have a lateral epicondyle, and the operative approach these days historically has been an open tenotomy, and that's what you see there. You can see with the retractors that kind of outline and border that angiofibroblastic tissue that's dark. Next to it is healthy tissue, tendon tissue in white, and then muscle, most distal. Before that patient was incised, we placed a transducer, and that's what we saw in the elbow. We saw healthy tissue in a fibular pattern superficially, and then a hypoechoic area, which is consistent with point tenderness, and in this case, was consistent with that necrotic tissue. And that's what we're designed, our therapy is to remove that diseased tissue to, again, as I said in my preamble, accelerate that remodeling. Next slide, please. So what we're about then is if we can devise a tool where the physician can do this at a outpatient setting, typically in a procedure room in an ASC format, where the patient's have been exposed to local anesthesia. So the minimally invasiveness is appealing not just only to the patient, but also to the physician. And here are the steps that we use our technique in. Our technique uses an instrument that provides a percutaneous tenotomy. It's a needle that delivers ultrasonic energy that's designed to only debride, cut, and remove that hypoechoic area, that necrotic tissue. You visualize it with the ultrasound, and just like you would do with any kind of needle-guided instrumentation or procedure, you guide our instrument through the hypoechoic area. You depress the foot pedal that imparts the energy. That energy removes that tissue. You know when you're done, and certainly our panelists can speak to that, is when you see a change in the hypoechoic area to something that looks more punctate. But also from a tactile sense, you'll feel that you've created a cavity. And that's our goal. Our goal is to remove that necrotic tissue, create a cavity, so that you have a healthy remodeling process that takes part subsequent to that. Next slide, please. We've treated, since our commercial launch in the early part of 2012, and this is just in the U.S., a number of patients. So we've treated approximately 30,000 patients, and that's the distribution from the body parts. As you see, a great majority of these are consistent with the epidemiology and the incidence that you see in your practice, perhaps, of elbow, most of which are lateral, and then plantar fascia. We've done a number of patellar tendons as well as Achilles, both mid-substance and insertional, and just a handful of shoulders. And that's primarily because the length of our needle is a bit short right now to treat most shoulders. At least I live in Minnesota, and our shoulders are a little fluffy over here. So as we come up with our longer instrument, that will allow you to adequately address deeper tissues, such as in the shoulder as well as in the hip. Next slide. Here's the instrument, and some of you may have been exposed to this by those that have exposed Tenex to you, but we have a needle that delivers the ultrasonic energy. It moves at a frequency that's specific to the necrotic tissue, and it uses the concept of harmonic resonance. And you see this actually in practice a bit more provincially when you think about the cast saw. That goes through plaster, but it's at a revolution of frequency that will not disturb skin unless you deliberately put it on the skin and burn the skin, because of the concept of elasticity of tissue. Necrotic tissue is dense, healthy tissue is elastic. That's what we take advantage of. So that needle breaks that tissue down. Around the needle we have a sheath. That sheath is designed to protect the subcutaneous tissue. Excuse me. The sheath also directs saline that is forced to irrigate that needle between the sheath and the needle to help keep that needle cool. And then the third thing that happens is both the tissue that you cut and debride as well as the saline that you irrigate, both are aspirated through the central lumen of that needle. So you're cutting, you're aspirating, and you're irrigating co-synchronously to effectively treat the tissue. Next slide. I know the panelists will speak about this, but some of the guidance we give to our physicians is, as I said in the outset, we are looking at that chronic population that has been recalcitrant to conservative treatment. And here's a snapshot that I would submit we feel works very well for our technology. They've had chronic pain for greater than 3 months. They do explain and present with point tenderness, and then certainly in the overwhelming majority of cases, that area of point tenderness would be consistent with a hypoechoic area by ultrasound examination. So that tells you definitively that's the tissue that you want to remove. So ultrasound is really more of a guidance to tell you where you want to impart the needle to deliver the energy and remove it. But certainly this is more of a clinical diagnosis than anything else. Next slide. We have spent a lot of time developing our clinical story set, and I would say we have about 17 publications, peer-reviewed, that are accepted or in print, and the majority of them prospective. And I'm just going to go through some highlights of a few. I will say we're very proud that these studies have been physician-initiated. The company took it upon themselves as a principle not to fund studies. As many of you know, that makes it difficult for you to secure acceptance to be published. Nevertheless, I'm going to give you some snapshots of the physician studies, again, majority of which are prospective. And I'll start with the next one. Nathan, if you can show that slide up. This is with the elbow. This is a study that has both 1-year follow-up as well as 3-year follow-up. The 3-year data was recently accepted about a month back in the American Journal of Sports Medicine. The 1-year has already been published a couple years back. But the design of the study, 20 patients, as I said, failed conservative treatment, single treatment with Tenex, no physical therapy post-treatment. You certainly can, but in this study they didn't. And then over-the-counter pain control. We followed them up from 2 weeks, and as I said, all the way out to 36 months. We looked at safety through adverse events, pain, and then a quality of life measurement as well. And the next slide, Nathan. Excuse me. So this bar shows, graph rather, shows the improvement in quality of life dash in red. You can see that improved immediately at month 1, but then it sustains itself. And then the same is true of the pain scores. Immediate improvement and then a sustainability, which to us at least reveals or suggests that there's no tachyphylactic response. I think many of you understand that in these tendinosis patients, there's a strong placebo effect. Our medical director, Dr. Mori, often comments that everything works 90% of the time the first month in these patients. So the real test of a therapy is the sustainability of its treatment. And we feel we have that because with that single treatment, the patients continue to get better and there was no kind of rebound, if you will, in terms of clinical outcomes. Next slide. This is a study that was out of Mayo. Dr. Barnes is a non-operative sports med physician. Dr. Beckley is an orthopedic surgeon, and Dr. Jay Smith is a PM&R physician. They looked at patients that had both lateral and medial epicondyloses. Again, similar type of framework, single treatment, failed conservative treatment. We followed those patients out from 6 weeks to 12 months. Again, looking at pain, looking at a range of motion score, male elbow score, and then the dash for quality of life. Next slide. And as you see in the next slide, you see a similar type of trend, improvement immediately and sustained out in both pain, quality of life, and then the range of motion, which is the male elbow performance score. So independently studied population, independently executed, and from the longevity, the studies showed the same type of outcomes, which was, again, very encouraging to us. Next slide. Dr. Elatraj, before I get to Dr. Elatraj, we recently submitted a paper for acceptance. This was our first randomized study. This was looking at Tenex versus the traditional open surgery. So their patients were randomized to the TX1 treatment or to surgical repair. We followed the patients out to 6 months. And you looked at efficacy for Tenex, which showed superiority to surgery, as well as post-treatment visits and then average work weeks missed. In the slide, you can hopefully certainly see the improvement that had a strong statistical differentiator between Tenex, favoring Tenex versus surgery. And then equally interesting was the cost effectiveness. You know, one would assume that minimally invasive therapy is less expensive, but this actually put a dollar figure to it. So we will certainly update everyone once this paper has been accepted for publication. Next slide, please. Dr. Elatraj, for some of you who might know, is a sports medicine surgeon at Curling Job. He looked at a number of patients with patella tendinoses. They were symptomatic for 6 months. He has a unique patient population where he treats high-end athletes, both at the professional and collegiate level. 10 of these 16 were collegiate-level athletes. Again, no complications. And that's one of the things that I think we have been very impressed with is the relatively safe profile of the therapy. There's no significant adverse events. We do chronicle them, and I'll share them with you at the end. But again, this study showed the same type of framework. Over 90% of patients had a relief of pain within 3 months and then sustained out at 6 months. And then in this case, all the athletes returned to the full level of activity. Next slide. I have a couple more on the lower extremity that I'd like to share with you. Dr. Patel is a foot and ankle surgeon out of Ortho Indy. He did 12 patients, again, recently published. These were for plantar fascia pain. 4 of the 12 had failed an open or an endoscopic fasciotomy. Again, single treatment, nothing else. We followed them out, as I said, for a year, and 11 of the 12 were pain-free at 3 months and then sustained. He also measured a foot and ankle quality of life, the fatty ACFAS score, measured those up at 12 months, and then that quality of life, similar to the upper extremity that you saw in the elbow, had a significant improvement. Next slide, please. Dr. Rosden on this slide looked at 100 patients, and this was presented earlier this year at the Society for Interventional Radiology, and this has subsequently been submitted for publication. But a larger cohort of plantar fascia patients, again, symptomatic for 6 months, not responding to conservative measures. As you see there, 100 patients, followed them up for a year, no complications, and then what he saw was both the pain and the quality of life improved at 2 weeks and have sustained all the way out to 12 months. 91% of the patients were pain-free at 6 months and again sustained at a 12-month interval. Next slide. And I think this one kind of finishes up some of the body parts that I wanted to highlight. This was an Achilles tendon. Dr. Ellis and Dr. Freed are podiatric surgeons in Phoenix, Arizona. They looked at 26 patients. These patients were symptomatic for a significant period of time. Single treatment with Tenex, nothing else. We were able to capture the cutting time as well, followed these patients up to 16 months. And here you see, again, approximately 90% of patients commented that they were relieved of pain within a month and sustained out to 16 months. And then over 90% would certainly have had the procedure again. So it certainly, I think, demonstrates a well-tolerated and certainly from a clinical efficacy standpoint appears to be a very compelling clinical efficacious technology as well. And then one of the things that certainly the panelists will speak about is in their own hands some of the safety profiles and the lack of significant complications. So we see this again not only in the community but also in the publications. Next slide here, real quick. One of the things we do is we kind of capture from the community, and we do this on a quarterly basis, what their experience has been. And the average cutting time, which is the ultrasonic time that's imparted to effectively treat the tissue, it isn't fixed, and it can be varied on operator experience. It can also be varied on the amount of lesion that is present to be treated. But roughly saying, when we poll the panel members as well as the faculty that come in for our symposium, these are the kind of numbers we get back of the treatment times from the elbow going all the way down to the plantar fascia. I think it's reasonable to expect that the plantar fascia is a thicker tendon, a thicker tissue rather, much more fibrous, so it takes a little bit longer to debride and cut all of that effectively. The bottom distribution graph really shows that we see in the community about a 90% effectiveness. But what we can't predict is when they'll get better. We see that about 80% of them get better in that 2 to 3 month period, and then there's a tail of an additional 5% that may take 6 months to have complete relief of their symptoms. And then certainly there are those that get relief very early on within a month post-treatment. Next slide. So I'm going to stop there, at least for the preamble, and I'm going to now kind of hand it over to both Josh and Mederic. And just by introduction, both these gentlemen have been using the technology in over 2 years. They were some of the early adopters of the technology, and they've certainly taught us much more than I think than we've taught them in terms of the technique. So hence, that's why we poll them to participate in the panel that you'll really hear from, as I said, the thought leaders in sports medicine. Some of you are familiar with Josh as well as Mederic. Josh is at the Andrews Institute where he heads up the non-operative sports med group. And then Mederic has the same bona fides at University of Iowa in the sports medicine group. So with that, I'm going to just put some questions to them and let them kind of give you their experiences. And I'll start off with you, Josh. If you can explain a little bit about your practice as well as what you used to use to treat patients with the chronic tendinoses before you were introduced to Tenex.
Thank you, Dr. Gill. I appreciate you inviting me on the webinar. My practice is a wide array of patients from adolescent all the way to the elderly. A lot of bread and butter sports medicine and quite a bit of arthritis. I started about 8, maybe 9 years ago using learning ultrasound and quickly recognized the importance of it and utility of it in my practice. And trying to treat tendinopathy, then our success, we had various ways to treat it, all of which were not extremely successful. I early on got involved with orthobiologics and started looking into platelet-rich plasma and treating tendinopathy. The problem with platelet-rich plasma is, number one, it takes quite a bit of time to work. You may have to use it, inject it more than once, and it's not covered by insurance, and it can be quite expensive for many. And then along came Tenex, and Tenex being covered by insurance, the results are relatively faster, and so I quickly started using Tenex instead of platelet-rich plasma initially for lateral epicondylitis of the elbow back then. And so I basically stopped using PRP for tennis elbow and started using Tenex for that indication, and then moved on to plantar fascia and jumper's knee, Achilles tendinosis, and so that's kind of how it started out in my practice.
Great. Thank you, Josh, very much. Dr. Hall, same question to you, a little bit about your practice as well as what you would do for these patients before you were exposed to Tenex.
Yeah, like Josh said, thanks for having me on the call tonight, Juggy. So my practice is a little bit different than Josh's. So I have a cohort of sports medicine patients that I'll see. So I'm a team physician at the University of Iowa as well as for some local high schools. So I have a good amount of young athletes who certainly have a lot of tendon disorders and a lot of overused tendon injuries as well as acute tendon injuries. And then the remainder of my practice is largely a referral-based practice that's probably more similar to a radiologist, really. And so I work in an orthopedic group, and I do all the diagnostic ultrasound imaging as well as any of the advanced image-guided procedures for the group. And so I get a lot of patients who will be sent to me who've seen other providers who are coming in to get a second opinion surgical consult or whatnot that gets sent over to me. And I have the good fortune at this point of really, getting to be kind of the gatekeeper of everybody who has a tendon issue that comes in into our system at this point. So before Tenex, I was doing similar to what Josh said, kind of the usual stuff. So you have the rehabilitation aspect of treating tendons, which we know works for a large percentage of patients, but certainly there's that percentage who just do not respond to any sort of rehabilitative measures. And then beyond that, from an interventional standpoint, I was largely using needle tenotomy, either with or without the platelet-rich plasma injections. And by and large, that was a fairly effective treatment. But as Josh mentioned, there were several problems with it. And one, it just took a while for folks to get better. It may take 3-4 months for them to see any meaningful improvement, and they did have quite a bit of post-procedure discomfort on the front end of that. So you often made people worse before they got any better, and it was always hard to predict how that course was going to go for folks. The length of time to time of improvement was also a bit more of an issue as I started dealing with higher level athletes, because every day sort of matters, and talking about the slow recovery, them not seeing early improvement began to become a little bit of an issue in my practice as I started to deal with higher level athletes for sure. And then with with the average Joe patient coming in, the out-of-pocket expense of PRP really is quite an issue. I know at my institution and many other large academic institutions, it's very expensive, and so that almost takes it off of the treatment algorithm for a lot of patients who just simply can't afford that out-of-pocket expense. And so it was challenging. In those cases, I was often left with just doing a needle tenotomy alone, and again, results were okay, but I felt like it was a little bit of an archaic procedure. We were kind of just taking something that we had lying around the office and trying to do a job with it that it wasn't necessarily designed for. when the idea of Tenex came along, I was very excited about it because I felt like finally we had a tool that was designed to do what we were trying to emulate, that we just didn't have the ability to do prior. So it just made a lot of sense to me, and then instituting it, was relatively straightforward since I was already doing the ultrasound imaging, already doing ultrasound guided procedures. The learning curve was, was pretty quick to gain use of the technology.
Perfect. Thank you. Very comprehensive, as always. Thank you, Derek. Derek, I'm going to stick with you. Again, three-part question. Share with the group, if you can, what you use, criteria you use right now for patient selection, those that you think would benefit from Tenex. That's the first part. Second part is, what are the different body parts that you've treated? And then if you can, third part to that is, qualify or quantify, if you might have it, your outcomes for those body parts. So again, criteria for patient selections, body parts you've treated, and then your outcomes per body part.
All right. So in terms of selection, so I've had kind of an evolving process in terms of my patient selection here. And so what I can share with the group is I think that as you start out, you should be pretty specific in your patient selection so that you have some good outcomes. Obviously, as you have something new, you want to start off and you're going to have a bit of a learning curve with the technique and getting comfortable with the procedure. I think you really want to pick patients who are going to do well. And as Juggy shared the current literature to date, we've sort of identified who these patients are really, and the outcomes have been very, very good. And then I think beyond that, then you can start to experiment with other patients who may have more challenging conditions who you think you might be able to help, but you're not quite sure. But I know that, and I talked to some folks who are just getting into things, and the first handful of patients they have are somebody who's failed 3 surgeries and this and that, and I'm like, well, you might be able to help them, but I don't know if that's quite the people that you necessarily want to start off with. And so the folks who do well with this are going to be people who have no question of their clinical diagnosis. So they're going to come in, everything on their clinical history and exam says tennis elbow. Then you look with ultrasound, and it looks exactly like tennis elbow, and you know exactly what you're doing. And so if you can really poke on the area, that's right where you see this hypoechoic lesion. They don't have any other confounding factors. Those folks, by and large, do very, very well. And I would say over the last couple of years, there's maybe 2 patients, out of the few hundred that I've treated that I thought were going to do well that haven't done well. So I really think that with good patient selection, you can have a very, very successful practice with this. And again, I think that's, people who are straightforward, their physical exam and their clinical history and their ultrasound exam all completely fit with the diagnosis that you're going after, and that's going to be for the major areas that were highlighted. So for the elbow, particularly the lateral elbow, which does very well, Achilles, plantar fascia, patellar tendon. In terms of body parts, obviously those are the main ones that we've done. I've done several different areas as well. I have done the shoulder. I've actually been doing more shoulder recently for whatever reason, and the shoulders can work very well. If any of you have been doing barbotage procedures or kind of the classic aspiration and lavage procedures, those are successful. But there's a handful of folks who you're not able to, to really adequately remove that calcium through a traditional needle lavaging procedure. And I found that Tenex works very well for those. I've been very happy. They tend to get that quick improvement, like you will find with those who have that very soft calcium that you can remove quickly. And so those have done well. But again, the patient selection is difficult just due to the size of the needle at this point. The lateral elbow does exceedingly well. There's maybe been one patient who hasn't done as well as I thought, but almost everybody does very well with a straightforward lateral elbow. The medial elbow do take longer to get better, and as the literature would suggest, it's just a little bit more challenging of a problem. They don't do quite as well, but that being said, if you have appropriate expectations and talk with patients beforehand, most are very satisfied at the end. So where I would say 90+% do better on the lateral side, excuse me, I would say closer to 80%, 75-80% on the medial elbow. will get the symptom relief they're looking for. I have done a handful of triceps tendons, and those have actually worked very well, including some high-level athletes with triceps tendinopathy. So that even though I don't have a very large experience, my experience has been very favorable in the ones that I have done. In the lower body, the patellar tendons have done very well. I've done quadriceps tendons, and I would liken the quadriceps and patellar to the medial and lateral elbow. So the quadriceps is just a little bit more challenging to get better, and it's a little bit different than the patellar tendon, but by and large, I have had good success with that as well. And then in the foot and ankle, the mid-substance Achilles does very well. That almost universally gets better. The plantar fascia does well with a qualifier, and so a lot of these patients may be very large BMI, and so if your BMI is 50, your feet are going to hurt, regardless of what you do. And so I'll have that discussion with patients, and if they have everything fits with plantar fasciopathy, and we do the treatment, they will get better. But I will explain to them that their weight is probably going to prevent them from being pain-free, and I feel like they have a higher recurrence. But by and large, those folks who do not have that problem have done very well. And then the insertional Achilles is the other area where expectations are really key. And so patients here have done much better than I expected, and my expectations were very low, so take that for what it is. But I found here with the insertional Achilles specifically that if a patient has a focal area that they can put their finger on where their pain is, and so not their whole entire heel hurts, but they really point at one focal spot, medial aspect of the insertion, lateral aspect of the insertion, and you look and you see a defined area of either calcific or degenerative tendinopathy at that location, those folks have done very well and have done as well as the other tendons in my experience. If they have a large amount of calcification, they have a Haglund's deformity, they have associated bursitis, then it's much more difficult to predict their outcome. I have treated some of those patients because their only other option was a large surgical procedure, which they didn't want to undergo. And several of them have been very happy with their outcome, although they weren't pain-free. And so we kind of discussed that on the front end of what their expectations were, what their activity levels were. And some of my happiest patients, maybe had gotten a 40 to 50% improvement in their pain, but that was, quite a bit for them. But again, if you can focus on those patients at the insertion who really have a very focal region of pain that corresponds with the lesion, they've done remarkably well for me. Perfect. And I think that covers most of my outcomes there too. We can talk about other specifics later, I think.
Yeah, awesome. Thank you, Dr. Hall. Josh, same question to you. Outline for the group your criteria for patient selection, the body parts you treated, and then in your hands, your outcomes experience.
I think all of the patients that I do, I want to see them having failed the traditional standard of care, physical therapy. I don't necessarily inject corticosteroid anymore, but many times folks will have had a corticosteroid injection. So if they've had 3 months or more of discomfort, pain, and they're just not getting better, then for the elbow, that's when I'll offer them Tenex. I've done probably 200 elbows. I'd say around 80 to 85% success. Just like Derek said, the medial side is a little more difficult than the lateral side. Having said that, they do exceedingly well, lateral greater than medial. My next most common area is the plantar fascia, where I've treated roughly 75, and they do quite well also, upwards of 80% in my practice. I typically, well, same things. They've tried the night splint stretching exercises, rolled a golf ball under the foot, And for plantar fascia, I typically will inject corticosteroid under ultrasound guidance. I'll either have done it or they've already had it done when they're referred to me. Regarding the plantar fascia, we did I have a foot and ankle department, surgical department here. We submitted a study. Juggy, I haven't told you about this yet. There was 30 patients randomized. Half the group got a gastrocnemius release by my surgeon. The other half randomly got Tenex, and both groups had about an 80% success rate. For the gastroc group, they were much more successful if they had very tight posterior structures, Achilles tendon. So that's been submitted to Foot and Ankle International, and we're waiting to see that. As far as the knee, I've done 50 knees. I was very surprised. This I'd say close to 90% success with jumper's knee. I've done several distal patellotendinoses, and I'll put them in a T-scope brace afterwards for a period of time and start them back in physical therapy. I don't think you asked me about post-operative protocol, so I won't go into that any further. And then the fourth area was the Achilles tendon, and as Maderick said, the mid-substance Achilles tendinopathy is the easier compared to the insertional. But again, an upwards of 80% success with that. So that's my practice.
Good. Thank you, Josh. I'm going to stick with you, Josh. And you touched on this a little bit. You've been using the product now for in excess of 2 years, and you've obviously refined and optimized your own post-treatment regimen. Can you share with the group what regimens you use after the procedure per body part? What do you do for the elbow, knee, and then foot and ankle?
Sure. Well, for the elbow, I'll tell them no anti-inflammatories. I'll put them in a wrist splint for 2 weeks. I'll just tell them to wear it all the time. I'll follow up with them 2 weeks after the procedure. I'll just examine their range of motion, make sure everything looks normal. If they have any tenderness at all, I'll then start them in physical therapy for roughly 4 weeks. And then I'll follow up with them at the 6-week post-op mark and reassess. Usually they're good to be discharged at that time. I discontinue that elbow wrist. Excuse me. I'll discontinue the wrist splint at 2 weeks, and so that's the elbow. For the knee, I put them in a T-scope brace locked out at about 30 degrees or so, just to protect them for the first 2 to 4 weeks, just depending on how they do. Again, I see them at 2 weeks, and I may open up that T-scope to 50, 60 degrees, and then I'll follow up with them several weeks later and continue to open up that T-scope brace as they continue to heal. I'll start a gradual, progressive physical therapy program as soon as they can tolerate it after that procedure, and it takes a little longer for those, in my experience, 6 to 12 weeks. Hopefully, you're discharging them. For the Achilles tendon, I put them in a fracture boot immediately after the procedure for about 2 weeks. I'll reassess and then hopefully transition out of the boot, maybe put them in a shoe with a silicone heel insert just to take some of the tension off the Achilles for a couple of weeks more. I'll start them in physical therapy immediately after the procedure as soon as it's tolerable. They may even use crutches after the procedure if they need it. Most can walk out because I'll do a tibial, I'll numb the area quite a bit, but crutches with a boot immediately after, and then a boot as soon as they can tolerate it. For plantar fascia, again, I use a boot. I do a tibial nerve block during the procedure, before the procedure, so that they have very little pain and they're able to usually walk out with the boot on. I'll see them again at 2 weeks. I'll usually start them in, not usually, but oftentimes I'll consider starting them in back into their rehabilitation when I see them, and at around 4 to 6 weeks discharging them. That's what I do for those.
Perfect. Good. Same kind of line of thought for you, Derek, if you can walk through your post-treatment regimen for these body parts.
Sure. So mine's fairly similar to Josh's, but maybe just a little bit less conservative. And so with the elbows, at this point, I don't give them any sort of brace or anything. I just sort of tell them not to lift anything heavier than about 5 pounds or so. Over the first 6 weeks, I let them walk out. If they're really feeling they need something, I'll give them a sling the first day. But I'd say, that's very rare at this point. I usually just let them walk out, tell them on the day after the procedure they should start doing range of motion, keep it within pain-free, and just avoid any heavy lifting and try to get back into light daily activities as tolerated. I follow them up at 2 weeks. At that point, if they're doing okay, we start them in some gentle physical therapy, again, keeping everything pain-free, but just starting to work on motion if they don't have full motion, and starting to just do a little bit of gentle strengthening. And then at 6 weeks, I'll start progressing them back, do a more aggressive rehab protocol, and start talking about return to work or return to sport. So I agree with Josh, around 6 weeks, we're hoping to get most of these folks back on the progression back to returning, depending on what their demands are for their work or sport. The medial elbow is largely the same, although I do expect it to go a little bit slower, but I don't necessarily do anything different in terms of restrictions for those. For the knee, I let folks have a choice, so they can either be non-weight bearing on crutches, or they can be weight bearing in a locked out knee immobilizer for the first 2 weeks. Again, I have them, if they are in the immobilizer, that's only when they're up bearing weight. Otherwise, I have them come out and start doing early active range of motion exercises, as soon as they can after the procedure, as well as start doing some gentle isometrics right away. I see them back at 2 weeks as well. At that point, if they're doing okay, we wean them out of any brace or off crutches and start having them start early rehab. I tell them it should be 6 weeks before they start doing any heavy loading, so there's no running, jumping, or anything like that for the first 6 weeks. But I will let them get on a stationary bike and do some other exercise. And then, by and large, it's usually going to be about 3 months before we're talking about a full, heavy return to play. I'm fairly close with watching these folks, particularly as they get back into any running or jumping sort of sports. Keep a little bit closer eye, both the patellar and the quadriceps tendons. For the Achilles, I have them wear a walking boot for the first 2 weeks, so I do let them bear weight immediately after the procedure, and I usually don't give them crutches or anything. They can kind of just go right in the boot, and that's for 2 weeks. I see it back at that 2 week point. If they're doing okay, we transition them out of the boot. I don't routinely use any heel lifts or anything else for these folks. I just tell them to start weaning out of the boot into a shoe before they go barefoot. That typically goes okay. If I'm really concerned about a large regional partial tearing in the Achilles, I might move a little bit slower, but that would certainly not be the norm. And then for the plantar fascia, I also let them bear weight right away in a walking boot. I don't keep them in a boot for that long. I tell them I want them in it for the first 5 days, and then I allow them to wean out of it as tolerated. So some people might still be in it at the 2 week point, which is okay. But if they're able to walk around in a shoe without any pain, I let them come out of the boot as early as 5 weeks. And I think 5 days, sorry. I think part of that is just a large percentage of these patients I've seen have been inappropriately treated with prolonged immobilization, and I really just don't want to keep them immobilized any longer. I will have them start doing some rehabilitative exercises as early as possible to try to regain their motion and their strength within their foot. I just find that to be a big problem with a lot of these folks, so we start getting on that fairly early. If they do have a job that requires them to be standing, I will have them use the boot judiciously to help with any pain and to allow them to get back to work as soon as possible. I don't like to hold these folks out of work, and that usually goes okay. So that may have them in the boot a little bit longer, but again, that's just for short periods of the day as they need it.
I'll get on that point a little bit, because one of the questions I get a lot, both for you, Josh, and Mederic, is the protection in the foot and ankle. And so just for the audience's benefit, do you use the relief of pain as one of your primary indicators to kind of remove the wearing of the boot, or are you kind of more steadfast that you really want to protect him for a period of time? I just want to make sure that the audience get your optics on that clearly. Mederic, can you repeat that guidance again?
Yep. And so for me, the way that I approach this is I think of what's the worst case scenario and what's the likelihood of that happening, and then I do it on a case-by-case basis. And so, is somebody going to tear their plantar fascia or tear their common extensor tendon? Probably not. And if it happens, it's not the worst thing in the world. If somebody tears their patellar tendon, that's a really bad deal. And that may happen, and I've seen that happen, not post-Tenex, but other things. And so that's kind of how I stratify. And so for elbows, I don't really care what they do. And for the plantar fascia, I don't really care what they do. I let pain completely be their guide, and I'm not that concerned. For mid-substance Achilles, if I feel like there's a lot of pathology there and I feel like the tendon health was really poor, particularly if the patient wants to get back to high demand activities, I do think there's a window with some of these folks where they'll feel much better than they actually are once you remove that noxious stimulus. A lot of folks will feel pretty good, so I may protect them a little bit beyond just their pain relief for those. For the insertional Achilles, again, usually there's a large percentage of that tendon that's still intact, and it's very rare to sort of rupture an Achilles tendon off the insertion, and so I'm much less concerned with those, and by and large, those folks are a different patient population that typically aren't trying to get back to very high demand running and jumping sort of thing, so I put them in a very low risk category for anything bad happening, and so I let pain pretty much be the guide for those. And so the only spots I'm really not letting pain be the guide for are going to be mid-substance Achilles and then patellar and quad tendons.
Okay, very helpful. Josh, would you elaborate on that as well from your side?
I like to use the boot for the Achilles for several weeks, as well as the plantar fascia. I just think the boot reminds the patient that they've had a procedure done. Whether they need it, completely need it, is debatable. But I use at least a 2-week mark for that. Regarding the patella tendon, for an ACL, they're harvesting the middle third of the patella tendon to use it as a graft, and they tend not to rupture. So, and what I found, I was very concerned initially about rupturing the patella tendon, but if you think about it, what you're taking out with Tenex, it's not providing any structural integrity to begin with. So removing it, we're not taking away much of the integrity of the tendon, at least in my opinion. And so over time, I've gotten more and more, or less and less, concerned about the patella tendon rupturing. Despite that, I'll keep them in a T-scope, gradually opening them up over a 2 to 5 week period. That still sounds a little more cautious than Mederic, so that's what I do with mine.
Good, very helpful. Well, let me do this. I'm sensitive to everybody's time. I've got a few questions that have come in, and let me kind of put them out to both you, Mederic, as well as Josh. So the first question is your advice on using PRP in conjunction with Tenex, and I assume it's probably just not PRP, but any orthobiologics. So orthobiologics plus Tenex in conjunction at the time of treatment. So Mederic, your thoughts on that?
So a couple of things. So I do not do this. I've maybe done it once at the patient's request. And the reason why is a couple. So first off, you're taking a procedure that's been covered by insurance, and now you're adding an out-of-pocket expense to it for the patient, really with no data to support that. And so I tell folks, listen, if we do this and it doesn't work and you still want a PRP, we can still do that. There's no problem with it. But in my experience, I had such good results with the Tenex, I don't really see that I need to charge them to do an additional procedure. Also, just from kind of a basic science standpoint, I mean, I think that after the actual procedure, you're probably getting, an adequate amount of growth factors that are coming in naturally, responding to the procedure to allow for healing. And so I just don't think that it's necessarily needed. If you were going to consider doing it, I think that I would not do it at the same time as the procedure, because what's going to happen is you've made this nice incision down, you could breathe this area out, you're going to put PRP in, and it's going to squirt right back out the incision and land on the floor. And so I would do it staged if you're going to do it. I'd bring them back and do it 4 to 6 weeks after you do the Tenex procedure, personally, because once you start doing this, you're going to find that after the procedure, there's a lot of that irrigation fluid that'll kind of leak out of the wound, and there is an open track down through there. So I just don't think your PRP is even going to stay there, even if you thought it was going to be helpful. I would definitely bring it back and do it later.
Okay, thank you. Josh, your response to that question about PRP plus Tenex?
Yeah, we see such a good result. I tell patients I don't really promote that idea. Now, if they come to the office and this is what they're wanting, and maybe they're a high-profile athlete, I will do it. And when I do it, I try and drain the area as much as I can. Just as Derek said, there's a lot of saline around, and so you do your best to try and dry the area as best you can. So the vast majority, I don't do it, but I'm not afraid of adding it to someone if usually they've failed several procedures. If they've failed an open procedure, or they've been treated for years with maybe a surgical procedure, and they come with the premonition that this is what they want, then I'm not afraid of doing it at the time of the Tenex procedure.
Perfect, good. Thank you, Josh. Josh, let me stick with you. Another question is, how many times have you had to retreat somebody with Tenex?
I could probably count it on my hand. I've done about 350. I'd say less than 10 that I can recall.
And again, this is not the question, but I'm reading into the question. Is that because not all of the area was treated, or you think that the disease continued on in an area that was at one time appeared to be healthy, that the point of tenderness was somewhere else? Any insight into that?
I assume I just didn't get it all. That would be the reason. They continue to have pain. Maybe the pain's better in one area but still persists in another. I just believe probably I didn't get it.
Yeah. Okay. Good. Derek, same question to you about retreatment.
Yeah, very similar to Josh. I've done maybe 5 or so out of the over 300 procedures that I've redone, and of those, handful, I think a couple of them, similar to Josh, I think I wasn't aggressive enough in my treatment, but there were a few that had recurrence of disease, and so they had obvious disease we treated. They actually had a good outcome, and then it's been, I think, a couple recently who did well for over a year. And then they started having recurrence of symptoms, and I just did one the other day that I rescanned, and in the interval they had some recurrence of disease, and I just treated a quadriceps tendon actually last week that had done well for like a year and a half, completely pain-free, and then had the same thing come back, and it was just a recurrence of disease. And so I think that is, I tell patients we just don't have enough long-term data at this point to really know what that percentage is. I think it's very, very low. but there will be some patients who, for whatever reason, may have recurrence of disease, and because they had, such a good outcome initially, they came back and they said, yeah, I think we need to treat this again. It worked really, really well. We just have the same things coming back, so you might see it.
The instrument probably reminds them they're going to the dentist's office and getting their teeth cleaned, right, on an annual basis.
Exactly.
The other question, I'll go with you here, Derek, is when do you know when the therapy has failed for your patients?
When the Tenex has failed?
Yes.
Yeah, so that's a good question, and what I tell people is 6 months. I would say that the first 6 weeks are pretty variable, in my opinion, and I still haven't been able to figure out who's going to be the person who gets a lot of early improvement over the first 2 weeks, and who's going to be the person who's really no better, and then starts to see that improvement later. But if they're not getting better by 2 months, I start to get a little bit worried, but I typically we'll kind of give the patient a pep talk and tell them to hang in there. And by and large, a lot of folks by that 3 to 4 month point, then we'll start to see, some improvement. But usually I'll ask them to kind of bear with me and ride it out up until that 6 month point before I start, looking at other advanced imaging or, re-looking at stuff, considering it a failure and talking about other treatment options. Some of the higher level athletes, obviously 6 months is way too long, and so usually it's going to be 3 months for them. But for other folks, especially older folks who I think just take a little bit longer to heal, I'm asking them to wait 6 months. But by 4 months, I'm probably getting a little bit concerned.
And is it one of these things where you're concerned because you don't see any improvement? Because if you go back to some of our published data, at least if you look at that, the graph shows some gradual improvement. While it may not be complete resolution, but gradual improvement. At the risk of putting words in your mouth, are you concerned when you don't see any improvement up at that 4 month period?
Yeah, so there's two groups. So if they're seeing gradual improvement, and I just give them a big pep talk and tell them it's going to keep getting better and better, up to a year, and usually folks will do okay if they're seeing improvement. The ones that I worry about are if they've seen zero improvement, feel they're worse after the procedure, which is very few, but I've had a couple, and if they've done well and then had sort of a recurrence. So say they felt like they were improving, they weren't cured, but they felt like they were getting better at the 6 week point, then you see them at 2 or 3 months, and they tell you that they've gotten worse, and now it feels like it's worse than it was before. Those are the ones I'm more concerned about. Yeah, if they're getting some gradual improvement, then I just continue to milk them along for a while because it seems like it is working, and usually they end up, being fairly happy with it.
Yeah. And can you quantify that percentage, that group right there, Derek, or the people you treated? What percentage fall into that category?
Oh man, that don't get better. I would say probably less than 5%.
Where nothing's working after a period of time.
Yeah, and I guess, and the thing that's tough with that is what I typically will tell folks is that I think that number probably of patients who I expected to do well, that number is probably less than 1%. I can tell you, I can name off the names of every patient who I thought was going to respond well to treatment and didn't. That's very, very low. That's probably less than 1%. But there's that other group where you kind of take a chance on them, and maybe it goes back to that patient selection. So maybe I'm not as surprised they're not doing well because they have some other confounding issues. And that's what brings that number up.
Yeah, good. Thank you. It's very helpful. Josh, we'll finish off with you with that same question in terms of when do you determine that the Tenex treatment has failed?
I use 6 months as well. I strongly recommend physical therapy, especially at the 3 month mark. And even if there's a small percentage of patients, if you get even more aggressive with their physical therapy after 3 months, and just increase the tempo instead of reducing it. It's kind of strange. We've seen that kind of for a small portion of those tennis elbows, especially they plateau, it seems. But if you get aggressive with their physical therapy, they seem to do well. I might even also consider to do platelet-rich plasma during that 3 to 6 month mark. So I'll offer that to them. Again, it's expensive, so it's not a common option to take up. But for the athletes, they tend to ask about that sooner than later.
Okay, and would you, are you in that same kind of estimate of patients that just don't respond at all with no success as what Mederic described, that's sitting around that 5% mark?
I would say yes, it's similar, yes.
Okay, good. Well, we've occupied an hour of your time, and I know we've occupied an hour of people that have joined in, and thank you all to them. Nathan, what I'd like to do, or at least for the remaining minutes, is open up the mics. If anyone has a question directed specifically to Dr. Hackle or Dr. Hall, so we can do that now, that'd be great.
Okay,
and once we open up the mics, we'll be able to hear everybody. Any questions out there?
Christy Hall, report. Christy Hall, what item said?
Okay, I don't think that was a question. Any other questions that we want to give to Dr. Hall or Dr. Hackle before we sign off?
I'm still working. There's about 30 people to do, and I have to do them one by one, so we're still going through the list here. There might be some people who are talking and we can't hear them.
Oh, got it. All right, thank you. We'll hold tight. You'll just let me know, Nathan, when we've all cleared it up.
Yeah,
everyone has
now been unmuted, so they should be able to talk.
Great. I'm surprised I don't hear any Monday Night Football in the background. It shows how vigilant these people are. Well, I think we've unmuted everybody. We can hear everybody now. So if anyone has a question for either Dr. Hackle or Dr. Hall, please feel free to pose it now.
I have a general question.
Yeah.
If a patient has had a steroid injection in any of the tendons, how long afterwards do you feel it's safe to perform the Tenex procedure?
Sure. So let me repeat that question so everyone here. So a patient has had a steroid injection in any of the tendons. How far after that steroid injection is it safe to perform the Tenex procedure? Josh, you want to handle that one first?
I don't really use. I'm not very concerned. Usually, when I see these patients, it's been some time, weeks if not months, from their steroid shot. I wouldn't necessarily do it a day after, but usually a couple of weeks at least before I would have the opportunity to give this as a treatment option. So it's really, I haven't had that issue occur within days, so to speak.
Mederic, how about yourself?
I just set a kind of a hardline date of 6 weeks. I want there to be 6 weeks between the last steroid injection and before I'll do the procedure, and that's more just for concern of potential delayed healing after that steroid injection. But that issue came up for me a few times, and so I just kind of made a policy at my office, just kind of off the top of my head. So that's what I use, 6 weeks.
And you also want to give it an opportunity, the steroid shot, an opportunity to work, hopefully.
Great,
yeah, fair point. Fair point. Thank you. Any other questions?
Yeah, guys, I appreciate you talking tonight. Real quick question: where do you actually perform the procedures? Is it in a procedure room, or is it dedicated to like an operative room or a surgery center, or are you pretty much just doing it in a normal room? And then what does your sterile procedure look like? And then also any anesthetic that you're using during the procedure?
So let me kind of put the question out there for everyone. So what was the point of care for the procedure? What was your sterile environment that you use? And then the third part of the question was, what was the anesthetic that you provide for the procedure? So Mederic, let's let you handle that one first.
All right, so I have a little bit of a unique setup, but I perform mine at my office, but I have a procedure suite at my sports medicine center, and we were able to bill out of that, effectively like an ASC. So So that's kind of a separate issue, but effectively it's just a procedure suite that we have set up. I prep the patient, I use ChloraPrep, and then I drape them out with sterile drapes over the area, and then use a sterile ultrasound transducer cover, sterile gloves, kind of the whole deal there. But we're not scrubbing in. I've got sterile gloves and scrubs on, and I'm not doing a full scrub. And then in terms of anesthetic, I typically just use a 1% lidocaine. I've been surprised at how little it actually takes to get the patient very comfortable. So I'll usually drop 5 to 6 mLs of 1% lidocaine for most procedures, and just give local anesthetic, and typically don't even need to use that amount to make them, pain-free during the procedure. I think Josh mentioned earlier, I will occasionally do some nerve blocks for the plantar fascia, but not for everybody. But I will for a select group of patients. I think it's very safe to do in a procedure type room, though, in an outpatient setting. I've not any concerns about that.
Great. Thanks, Derek. Josh, how about for yourself?
I must say I'm extremely jealous of Derek's situation. I have to use the operating room in our surgery center. In our facility, I have to do that in order to bill the technical and professional fee. Now, if they don't have insurance, I will do it in the office, and the same prep goes as Derek said. But the 99% of the time, it's in the operating room. We do not have if we had a procedure room in our surgery center, I would be doing it in the procedure room, but I don't have the benefit of a procedure room, so I'm doing it in the operating room with the same prep as Derek just described.
So this is Juggy. I will tell you, across the board of the over 500 physicians that we have doing the procedure, and don't hold me to these numbers, what rough estimates, 90% of them are done in a procedure room, in an ambulatory surgery center, and then the balance are done in a operating room, in a hospital setting, an outpatient hospital setting, or in a office setting, similar to what Derek described. But again, 90% of them are done in a procedure room in a ASC format. Any other questions from the group?
Yeah, guys, thanks for answering that question. One really quick one. All of the areas that you mentioned, elbow, knee, Achilles, and plantar fascia, are all those covered under insurance? And are there any other areas that are covered in insurance or are not that you do?
No.
Josh, I'll let you take that one first, and then we'll let Derek give his comments second.
All of the areas that I have mentioned are covered by insurance in Florida, where I am.
Derek, for yourself?
Yeah, so we've gotten everything covered by insurance as well. So those areas that were mentioned, including also for me, shoulder, triceps, various other areas, you have to be a little bit savvy in how you bill. And so there are not percutaneous tenotomy codes for every region, and so you may have to bill it as an unlisted code. But when we've done that and then kind of documented everything appropriately, we have been able to get reimbursement for all the areas that we've treated so far.
And for those audience members, if you have questions about the specific codes, the specific dictation templates, and we include the dictation templates, feel free to reach out to your reps. And then if they have questions, they'll certainly flow that up to myself, and I'll be happy to help as well. Any other questions? Yes, thank you. Awesome. Well, I don't hear any other questions. First, I want to thank everyone for taking the time in the evening. I know there's other commitments for jumping on. Very greatly appreciated. And then very forthrightly want to thank Dr. Hackle and Dr. Hall. They always are impressive in terms of the delivery. So thank you, as always, for a very comprehensive presentation. So with that, I'll let everybody go and a bit of final thank you again, and enjoy your evening.